Good day, ladies and gentlemen. Thank you for standing by. Welcome to the Actinium Pharmaceuticals, Inc. Iomab-B Expert Panel Webinar and Conference Call. During today's presentation, all parties will be in a listen-only mode. Following the presentation, the conference will be open for questions. You can submit questions electronically by email at iomab@actiniumpharmaceuticals.com or through the Ask a Question button located on the webcast viewing page. Please press *0 for operator assistance at any time during the call if you need assistance. This event is being recorded today, Tuesday, October 15th, 2013. I would now like to turn the conference over to the moderator of today's panel discussion, Mr. Magid Sanuda. Please go ahead, sir.
Thank you and good morning, everyone. Joining us today for our webinar are Dr. Kaushik Dave, President and CEO of Actinium Pharmaceuticals, and three esteemed physicians, Dr. Hillard Lazarus, Dr. John Pagel, and Dr. Richard Wall. Before we begin, I'd like to remind everyone that during this conference call, any forward-looking statements made by management are intended to fall within the safe harbor provisions of the Private Securities Litigation Reform Act of 1995 and Section 21E of the Securities Exchange Act of 1934 as amended. These statements are based on management's current expectations and involve risks and uncertainties which may cause results to differ materially from those set forth in the statements. The forward-looking statements may include statements regarding product development, product potential, and financial performance. No forward-looking statement can be guaranteed, and actual results may differ materially from those projected. For more information regarding these risks and uncertainties, please refer to the company's filings on Form 10-K, 10-Q, and 8-K with the SEC. For those who are unable to listen to the entire call, there will be an archived webcast that will be available on the Investors section of the company's website. The call is also being webcast live, so you can log in via the Internet to review slides related to the presentation. At this time, I'd like to turn the call over to Dr. Kaushik Dave, President and CEO of Actinium Pharmaceuticals, who will provide opening remarks.
Thank you, Magid. Hi, I am Dr. Kaushik Dave, President and CEO of Actinium Pharmaceuticals, Incorporated. We are a publicly traded biotechnology company with groundbreaking targeted payload therapies. It is my pleasure to welcome you all to the webinar on Iomab-B, which has the potential to revolutionize and expand the use of bone marrow transplant. Iomab-B is a breakthrough therapy for acute myeloid leukemia in elderly patients with currently very limited options for curative treatment. Significant clinical data generated to date, which includes Phase 1 and Phase 2 proof-of-concept clinical studies, are compelling. A large safety data with over 250-plus patients has been collected. Due to Iomab's safety and efficacy profile, it can potentially disrupt the field of bone marrow transplant. These clinical trial results have attracted significant interest from the medical community. Our technology involves monoclonal antibodies conjugated with radioisotopes. These targeted delivery therapies allow selective delivery of radiation to cancer cells and, as a consequence, killing these cells with minimal side effects on other body organs. We are leveraging our technology to address unmet medical needs in several different types of cancer. Actinium has an active and robust development pipeline with programs from preclinical to late-stage clinical development. The first two programs, Iomab-B and Iomab-A, have clinical data and so have been de-risked. However, today we will only cover Iomab-B for refractory and relapsed acute myeloid leukemia. So what is Iomab-B? Iomab-B consists of BC8, a monoclonal antibody, which is labeled with a radioisotope. BC8 antibody binds to CD45, an antigen found only on white blood cells, which allows highly specific binding to these cells while avoiding other cells. The radioisotope is attached to the BC8 monoclonal antibody. In that way, the antibody delivers radiation directly to the target cells by avoiding healthy tissues. Iomab-B is a breakthrough therapy for myeloconditioning prior to BMT, particularly useful for very sick elderly patients currently without any curative treatment options. There is an extensive experience of 250-plus patients from 5 phase 1 and phase 2 clinical trials. Iomab-B was in-licensed from Fred Hutchinson Cancer Center, where there are 7 ongoing physician trials with BC8 monoclonal antibody. The initial indication we are pursuing is to condition bone marrow in refractory and relapsed AML patients over the age of 50 in order to prepare them for BMT. Patients suffering from active refractory acute leukemia, especially the older patients, are currently not considered eligible for bone marrow transplants without being in remission, while the fact that they are refractory means that they are not responding to chemotherapy. Vast majority of these patients currently have no options for a potentially curative treatment. This is the unmet medical need which Iomab-B will address. The current approach to BMT in refractory acute leukemia patients is to attempt multiple rounds of high-dose chemotherapy. It typically takes a month or 2 from the cycle start to get to the point where a patient can undergo myeloconditioning and subsequent bone marrow transplant. And very few patients ever reach that point. In contrast, the Iomab-B treatment regime would be available to almost all the patients and require only 6 to 10 days of a much safer treatment. Furthermore, in addition to demonstrated survival benefits, Iomab-B treated patients are expected to experience reduced post-bone marrow transplant complications. Results from previous clinical trials in refractory and relapsed AML patients were impressive. In these group of patients who had no curative treatment options, Iomab-B conditioning combined with reduced intensity conditioning in patients not in complete remission resulted in a 100% complete remission rate, leading to about 20% of patients surviving leukemia-free beyond 2 years. Compared to historical data in similar patient population where no one survived out to 2 years, yes, no one, you must agree this is a significant improvement. From basically no long-term survival or only sporadic long-term survival, we may be able to offer hope to 1 in 5 patients of long-term survival. Equally importantly, this survival benefit is coupled with safer and milder side effects, since there were no additional increase in treatment-related mortality from introducing Iomab-B into the regime. This breakthrough treatment will also be evaluated for other indications, such as myelodysplastic syndrome, acute lymphoblastic leukemia, non-Hodgkin's lymphoma, and Hodgkin's disease. Iomab-B has already been successfully used in clinical trials for these indications. In addition, BC8 labeled with another isotope is currently in a clinical trial for transplant in multiple myeloma. We will be discussing our leading program, Iomab-B, for the treatment of refractory acute myeloid leukemia with world-renowned experts, Drs. Lazarus, Pagel, and Wall. It is my pleasure that they are participating on the expert panel today. Over to you, Maggot. Thank you.
Thank you, Dr. Dave. My name is Maggot Shimuda. I've been a biotech analyst for many years, and it is a real pleasure to discuss such an interesting new technology. With me today, I have a panel of experts who have already left an indelible mark in the field of hematology, bone marrow transplants, and nuclear medicine, areas that this treatment spans. My guests continue to be on the forefront of medicine, as I'm sure you'll hear in today's discussion. They are Dr. John Pagel of the Fred Hutchinson Cancer Research Center, who is the key clinician in the development of Iomab-B. Dr. Hillard Lazarus of Case Western, one of the pioneers of bone marrow transplants and among the greatest experts in the field. And Dr. Richard Wall, father of PET imaging and oncology in the U.S. and co-inventor of the first approved radioimmunopharmaceutical drug. Let's start with our panel. Dr. Lazarus, if we look at a disease like acute myeloid leukemia, you and your colleagues are now able to cure less than 10% of older patients whose prognosis is otherwise universally fatal. Yet most of the patients are not even offered a potentially curative option. Why is that?
Well, most of the patients who don't track to a transplant do so because they are not in a complete remission. The disease is still active, and given current approaches would not likely benefit. Also, a lot of the patients may have what are called comorbid conditions, meaning they have a organ that isn't working, the kidney or the lung, or they are too old to tolerate the standard approaches. So those are the two major reasons for people not getting to a transplant. Until somewhat recently, a third reason was that patients did not have an adequately matched donor, and that's actually changed in recent years with the more than 20 million volunteer adult donors that are available and other sources of hematopoietic cells. The people not going to a transplant has been really reduced because there is a graft for them. So the third reason probably that has moved up are both physician and patient attitudes regarding this approach, and they're scared off because of potential toxicities of the procedure.
Is the situation the same across the patient population, or is it any different for older patients with acute active myeloid leukemia?
Well, the older patients, like anything that gets older, has less resiliency, whether it's a rubber band that you're stretching or it's a refrigerator or an automobile. And certainly the case of a patient, the organs don't tolerate therapy. There's nothing in medicine that is all good or all bad. It's shades of gray. And the treatments that are administered to eliminate malignancies will damage normal tissues as well as the malignant tissues. The concept is that malignant tissues are less able to repair damage compared to normal tissues, and so one has to support the individual who's receiving the therapy to get through this period waiting for the normal organs to recover. So it's a two-edged sword, and as people age, it becomes much more difficult for them to bounce back, and if they don't fully bounce back, then we incur what's called treatment-related mortality, where the treatment has caused the demise of the patient, not the malignancy.
Dr. Pagel, we've heard from Dr. Lazarus that there are quite a few limitations to bone marrow, or more accurately, hematopoietic stem cell transplants. Yet it looks like their use is on the rise. Is that really a trend? And if yes, how do you explain it?
Well, there are many possible reasons for why a patient may not be able to get a stem cell transplant. Over time, we've made big strides on all of these fronts, and the condition will continue to improve, and the number of transplants obviously will continue to increase. As a matter of fact, stem cell transplantation is the fastest growing hospital procedure in the United States. There are all wider trends that are dependent on appropriately broad-based efforts. I would say one issue that needs to be addressed in a quicker, more focused way is the matter of leukemia patients with an active disease, perhaps even with refractory disease. So to transplant a patient successfully, we ideally want to treat the patient's blood and bone marrow as well as the other organs to completely clear it of leukemia. And as part of the transplant, we, of course, eradicate often the normal healthy blood cells. So when we give a patient these healthy stem cells back, we, of course, want them to find a very receptive, hospitable environment in the bone marrow and not to clash, perhaps, with the existing immune system of the patient. So first thing, of course, we have to destroy the cancer cells completely, as well as typically the other blood-forming cells. That's part of the ablative type of transplant. But that's perhaps easier said than done. You can imagine the wholesale destruction of blood cells typically requires administration of massive doses of total body irradiation, and typically sometimes combined with high doses of chemotherapy. These are what we call high-intensity regimens or myeloablative regimens. And of course, younger patients can tolerate this more often. They can tolerate it without a major problem. There is some, of course, physical cost, and many of the older patients cannot take this difficult treatment.
Thank you. Dr. Lazarus, can you place reduced intensity conditioning into this framework?
The concept here is that up until some elegant studies that were done in the dog model by Rainer Storb, which were validated in various clinical trials, showed that you don't have to throw the kitchen sink at the patient. The concept was that you need to really give super lethal doses of chemotherapy to get rid of the disease, and also allow the cells from another person to engraft or to grow. If you don't give enough chemotherapy or immunosuppressive therapy, then the cells from the other person won't grow. That's called engraftment failure. And so it used to be thought that very high doses were necessary to do both getting rid of the malignancy and allowing engraftment to occur. This has been significantly modified, and the paradigm which is being looked at in randomized prospective studies is comparing the more conventional older approach, so-called myeloablative conditioning, versus reduced intensity conditioning or non-myeloablative conditioning. There the concept is to administer enough therapy to turn off the recipient's immune system and allow the cells from the donor to go into hematopoietic areas and grow, and that's obviously safer, and then the person's own immune system will not be there. It'll be the immune system of the donor cells, and those are normal cells, and those will seek out and identify the malignant cells and kill them off. And that may take a little longer. So it's in concept a safer approach, although clearly when the graft is fully grown, there may be many of the same side effects, opportunistic infection because of the need for immunosuppressive therapy, and the dreaded graft, the two-edged sword of graft versus host disease compared to graft versus tumor, the so-called, that's a slang expression, that's really the allogeneic effect. So there is certainly morbidity and potential mortality, but up front early on it appears to be a safer approach. Randomized prospective studies now are being undertaken comparing, as I said earlier, the patients who could get either a myeloablative or a reduced intensity transplant. They're now being studied prospectively to see if one is in fact preferable compared to the other.
So is the reduced intensity conditioning the solution for older patients with refractory acute myeloid leukemia?
Unfortunately, this approach can't be used exclusively, I should say extensively, in older patients with an active disease. A reduced intensity regimen will really only work if the patient is typically already in remission, meaning that there are no detectable leukemia cells or a very low level in his or her bone marrow, or at least if the cancer is continuing to be sensitive to chemotherapy. So in these cases, lower doses of radiation combined with chemotherapy can typically successfully eliminate the leukemia cells, in addition to suppress the patient's immune system enough to allow for the newly infused healthy cells to settle again in the marrow and, as we say, engraft, and then again those immune system cells from the donor to eradicate any residual leukemia. The hard part is if the disease is still active and perhaps not even sensitive to chemotherapy, and so active meaning a significant disease burden, perhaps in refractory or relapsed leukemia patients coming into transplant. And in those settings, reduced intensity conditioning likely won't work very well, and we won't be able to get rid of the patient's leukemia cells well enough, despite even durable engraftment from a patient's donor's immune system cells. So even if this new cells engraft, which they typically will, they won't be able to dispose of the remaining leukemia cells because the burden of disease is just typically too high, and thus the disease will continue to relapse or come back, typically with a vengeance within perhaps a couple of months, and eliminate any development of normal, healthy, engrafted cells. So an obvious approach is to put these patients in remission first. So you want to minimize the amount of leukemia cells going into transplant. But we can't always do that because they're not typically, patients may not be able to tolerate more therapy, more chemotherapy or more radiation. They may have comorbidities that will make that difficult, or perhaps it won't even work. Patients can really have very refractory disease. And so we need to find a way of delivering lots of radiation or other therapy directly to the cancer cells, which are resistant to chemotherapy. So typically targeted delivery of radiation to the cancer cells, at the same time avoid delivering very high doses of radiation to normal tissues, which you might see with a nonspecific total body irradiation routine.
Dr. Lazarus, what do you think of this approach?
Well, I mean, that's the holy grail of medicine, giving enough treatment to do the job and not too much treatment to cause damage. That's clearly, the major drawback. As I said earlier, there are no medications or treatments or strategies that are all good and no bad. Targeted therapy with this radiation that's seeking just the malignancy is more likely to be much safer and better tolerated, not only from a physiologic standpoint, but from a mental standpoint. I mean, as I alluded to in the beginning of this discussion, patients and physicians' perceptions of not going to a transplant have a lot to do with people not wanting to be sick, not wanting to be in pain. I think that, and this is my own personal belief, that patients are more likely to understand, yeah, I have this cancer and I'll put up with the cancer, but I'm really afraid of having, being on a respirator for lung injury or having dialysis for a kidney injury. So if you can show that these treatments are safer and that there's a greater safety net, there'll be better acceptance and giving that patient a chance to survive. Again, giving the higher doses where they're needed, not to the innocent bystander organs.
Dr. Wall, you're a preeminent expert on radiation. We were told how these older patients can take lower doses of radiation but cannot survive the doses associated with myeloablative regimens. Why is that? Are the differences in doses really so big that myeloablative conditioning is lethal and reduced intensity easily tolerated? Are we talking about lots of radiation in either case? After all, many cancer patients receive lots of irradiation and they can tolerate it.
Yeah, that is a good question. As people age, their blood vessels weaken, they get narrower, the tissues become less strong, the repair capacity declines, so that in general it is more difficult to tolerate radiation. The patients who are older can receive radiation and often do receive fairly high doses of radiation, but remember that most external beam radiation is focused on a limited area of the body. When you start radiating the entire body, as is done sort of in a myeloablative regimen, this lack of tolerance, the more difficult recovery to radiation comes into to the fore. So there is really a difference between local radiation and whole body radiation. The bloodborne cancers have the challenge that they're not really localized. They have tumor pretty much distributed every place there is blood. So you can't focus the external radiation beam just on some limited area. You need to basically do whole body radiation, radiate the entire body to get rid of malignant blood cells. And this is called total body irradiation. And this is where patients can get into trouble in quite a hurry. So as an example, if you're looking at a full intensity myeloablative regimen to do your best to get rid of all the cancer cells as a part of a conditioning regimen, the patients might receive 10 to 12 gray of total body radiation. This is a lot. Reduced intensity conditioning will use 5 gray or even 2 gray. Of course, these lower doses aren't as tumor tumoricidal, so that's the delicate balance. But the 5 gray versus 10 gray or 5 gray versus 12 gray, just to think about it, in the range of 4.5 to 5 gray is the median lethal dose from whole body radiation. So half patients who would receive 4.5 to 5 gray would die unless they received a transplant. So at the dose of 10 to 12 gray, there's virtually no chance that the patient can survive without rather prompt blood stem cell transplant and aggressive medical management. So in sicker, particularly elderly individuals, surviving these doses that are 2 or more times the LD50, the dose that could kill 50% of them without transplant support, is quite challenging, even with aggressive medical therapy. These high doses, including in the elderly, can, that is like in the 10 to 12 gray range, can cause cerebrovascular syndrome with brain swelling, but also quite difficult to manage as damage to the bowels, the GI system, where patients can have bloody diarrhea, damage to the bowel, and reduced blood function, so they'll need a transplant. But whether they can survive this because of the bowel damage, loss of electrolytes like potassium, can be problematic because when potassium drops, heart function can decline or be interrupted, which obviously isn't a good thing. The other thing is, as blood counts get very low, there's a risk of sepsis, a bowel perforation because of the damage to the bowel, and so on. So this is harder in a young person, but particularly hard in an older person. So being able to lessen the total body dose and get it more to tumor is very important. We want the radiation to go to the tumor and ideally avoid the brain, the bowel, and other places where major toxicity is seen. So I just want to make it clear that very high dose radiation is quite dangerous when given by external beam, particularly in the elderly. So reducing that dose would be extremely helpful if tumor control can be achieved.
Well, following up on that, Dr. Pagel, how do you manage to deliver otherwise lethal doses of irradiation only where you want them, and to avoid brain, bowel, and other tissues where that much irradiation can wreak such havoc?
Well, let me start off by saying that I fully agree with everything that Dr. Lazarus and Dr. Wallace pointed out. We know that if we give patients over the age of 50 very high doses of radiation, they will, and in many and probably most cases, have a lethal complication, a fatal complication. On the other hand, these reduced intensity doses work in some patients, but we know from studies that the more radiation we deliver, the higher the chances that the subsequent transplant will cure the patient. So there's a dose response here. The more radiation we can get into patients, the less chance we have for relapse, better chance for cure. And that's why we're looking for ways to use both the best approach in all worlds. That's to deliver very high radiation activities directly to the blood cells, but not to the healthy cells. And we found an ideal vehicle for that in using monoclonal antibodies. These are biological vehicles that are used to deliver therapy directly to cancer cells. They're able to target those cells. The reasoning was that if we have an antibody that can bind to blood cells and not the normal tissues, perhaps like those in the GI tract or the heart or the lungs, then we can arm that antibody with perhaps some payload or a carrier, or in this case a radioactive isotope, and the antibody will take that radiation directly to the blood cells and target those cells and use the radiation to kill those cells, again without inflicting all the damage to healthy tissues as Dr. Wallace described. We actually have an exon antibody, we believe, for that purpose. It's called BC8, and it specifically targets CD45. That's an antigen that's found on the surface of pretty much all blood cancer cells and nowhere else in the body. Once we attach the radioactive isotope to that antibody, vast activities of radiation are able to be brought directly to the cancer cells and avoid the normal tissues like the bowel, the brain, the vasculature, the heart, and the lungs. we've treated, well, more than 250 patients, close to 300 patients with BCA-based radioimmunotherapy. That's the anti-CD45 targeted delivery of radiation by the antibody. And it's, I think, been a success in many ways. Among the patients we've treated, most of them have been older acute myeloid leukemia patients who have been in active relapse or refractory, in a refractory setting, meaning that they haven't had even a response to treatment. And this is what Dr. Lazarus has mentioned as an example of a group that is really, I guess, truly untreatable with standard treatments in these days. If you look at the outcomes for these very, very difficult patients without our treatment approach, certainly fewer than 10% of them survive to 1 year. And among those with really bad chromosomes or cytogenetics, 1 year survivals are probably 2 to 3% at best. Effectively, none of these patients will survive 2 years. So really bad patients, as you can imagine. And when we've treated these patients with anti-CD45 BCA-labeled antibody using radioactive iodine-131, we've had well more than 30% who have survived a year, and we have well more than 20% who are alive 2 years later. Not only that, but among those who have survived 2 years, relapses have been extremely uncommon, and these patients have largely been cured. In fact, we have a patient that I just saw recently in clinic as a follow-up who's still alive, well, no trace of the disease. One of these extremely high-risk patients who's now more than 7 years out from their radio-labeled antibody-based transplant, doing very well. We were able to turn this, I think, an untreatable disease in many aspects into not only a treatable one, but to actually cure a significant number of these patients. So one might wonder how that's possible, but I think it's a logical outcome to our approach. With our drug candidate, we were able to deliver and can deliver safely to the sites of leukemia absorbed doses of up to at least 24 gray, while the dose delivered to the whole body was well below 1 gray. So again, this gets to this idea of giving very high doses of therapy directed directly to the cells that you want it to go to and limiting the amount that goes to the normal whole body.
This is certainly exciting news for patients. Dr. Wall, we're now talking about really high doses of radiation. Is this approach feasible in hospitals, given the shielding requirements and safety issues for the personnel?
Yes, I do think this is exciting, and the point that's important, again, is that these are really high doses targeted quite specifically to the tumor cells and not nearly as much to the normal tissues. So it's quite high tumor-specific radiation, and that's really what we want to achieve. Your question deals with the logistics of giving high-dose iodine-131 labeled antibodies, and the fact of the matter is facilities that do this have to be trained and experienced to give high levels of activity. A lot has to be given, a lot of radioactive molecules, to get a lot of radioactive molecules to the tumor. So the patients definitely will be radioactive. However, this kind of work is done all the time in hospitals that see thyroid cancer, which is quite a common cancer. So in patients who have metastatic thyroid cancer, the doses that would be given with this therapy are of the leukemia are in line with those that are given to patients with advanced metastatic thyroid cancer. So most hospitals that treat aggressive thyroid cancer with high-dose radiation should be able to handle the radiation requirements with this radiopharmaceutical therapy agent. And this is certainly, Dr. Pagel has described some of the logistics with this, but it's completely feasible, so it's not a large leap of technology at all to be able to do this in most hospitals that see thyroid cancer.
Dr. Pagel, you've used BC8 I-131 extensively in patients. Can you confirm the safety profile estimates that Dr. Lazarus predicts?
For sure. In clinical trials that we've conducted, treatment with the BC8 anti-CD45 antibodies resulted in relatively few toxicities beyond those which are expected with the standard reduced intensity conditioning approach. Notably, on average, the estimated radiation absorbed doses that are delivered to the marrow are 1.5 or 2 times greater than that that's given to the liver, and doses in the spleen are 4 to 5 times greater than that's delivered to the liver. Again, these are doses delivered by the radiolabeled antibody directed to sites of disease, the marrow and the spleen as those examples. And the ratios then of radiation delivered to the marrow and spleen compared to, let's say, the lung or the kidney or the total body are even greater than what they are to the liver. Importantly, engraftment of the stem cell transplant has not ever been shown to be delayed after treatment, and for the most part, infusion of the radiolabeled antibody and its related toxicities are usually very mild and very manageable.
You pointed to the area of relapsed and refractory acute myeloid leukemia as an example of where the drugs like BCA radioimmunotherapy are needed. Do you think that this approach could also be useful in leukemia patients who are eligible for myeloablative regimens? What about other indications in hematology?
Well, I think that any treatment that shows efficacy in a very advanced or poor risk or refractory group of patients piques our interest in 2 areas. One, if something works at the end of the line, why not use it in earlier? And we often do this. Treatments that were developed in end-stage diseases, very sick patients that work, get moved up further and further, and sometimes become the frontline treatment. This approach, if it works, will not just be used in relapsed or refractory patients. It'll be used earlier, and it might actually be used in young patients as part of a myeloablative regimen. So there's a lot of opportunity to move this up in leukemia earlier and earlier, not waiting for the disease to be refractory, perhaps targeting patients that have biologic indicators for having high-risk disease. That is, the standard myeloablative approaches are not curative in poor-risk cytogenetic patients to the same degree that they are in intermediate-risk cytogenetic patients. The other area is clearly in diseases that are malignancies confined to hematopoietic tissues. So, for example, certain kinds of lymphomas, certain kinds of plasma cell dyscrasias like plasma cell myeloma. If the malignancy is in the hematopoietic tissue and you have a targeted therapy that goes to these hematopoietic tissues, then in theory, this treatment could be used in other hematologic malignancies.
We've just heard from Dr. Lazarus that the drug can be used in indications beyond AML. Does your clinical experience confirm the expectations set previously by some of the respondents?
Relapsed and refractory acute myeloid leukemia, or AML, is certainly not the only disease state where an ability to deliver more radiation safely is of paramount importance. The same applies to many cases of acute lymphoblastic leukemia, ALL, certainly many cases of myelodysplastic syndrome, perhaps some Hodgkin disease, or maybe even non-Hodgkin lymphoma. Even the patients who can't take the full course of a myeloablative therapy would be better off not having to go through that. They may not die as a result of it, but it's very tough and arduous treatment, and the antibody can help to avoid these things by taking the drug, the anti-CD45 radiolabeled antibody, directly to the tumor site, as has been well described here. As a matter of fact, we're currently running a trial that enrolls relapsed and refractory acute lymphoblastic leukemia patients. We also have trials in non-Hodgkin lymphoma and multiple myeloma. So people with all these different indications are already benefiting, albeit on a relatively small scale. We hope to have the approval process accelerated soon so that more patients will have a hope of a cure, where until now they've only had a certainty perhaps of death.
At this time, we would like to ask our participants to please submit their questions via the Ask a Question chat window located in the left-hand portion of the webcast browser window. We will then read the question out loud and direct to the appropriate panel physician. I would now like to turn the call back over to Maggot Kinuda, who will direct our first question.
Okay, thank you everybody for holding, and I apologize for the technical difficulties. So the first question comes in from one of the webinar viewers. The question will direct it to Dr. Pagel. Dr. Pagel, who treats the patients, oncologists or radiologists with this potential treatment? Does the separation create a hurdle for patients getting to these new agents?
That's a good question, especially in the era of prior radiolabeled antibody use. This is an interdisciplinary, multi-team effort. That's typically how stem cell transplants are performed anyway. They're not isolated, one physician typically performing a transplant. These are teams that do this, and those teams are always very interdisciplinary and working together. So typically the oncologist who is treating the patient will work with either a radiation oncologist or a nuclear medicine physician to deliver this therapy. But that's not out of the norm for how transplants would work. This is something that's very feasible and something that has been easily accomplished from a teamwork standpoint in the past.
Great, thank you. Next question we'll direct to Dr. Lazarus. Dr. Lazarus, you seem to imply that bone marrow transplants are still underutilized in general. Why is that so, and how do you think it can be remedied? I think we may have lost Dr. Lazarus on the line. Dr. Lazarus? Okay, well, we'll direct the next question to Dr. Pagel in the interim. Dr. Pagel, your focus has been on allogeneic transplants. Could labeled BC8 be used in autologous transplants as well?
Oh, sure. The ongoing trials we have in relapsed and refractory Hodgkin lymphoma and non-Hodgkin lymphoma use autologous stem cell transplants. That's a feasible approach and ongoing, so there's no reason why radiolabeled BC8 antibody would not work well in an autologous transplant just like it does for the allogeneic transplants as we've been talking about. In terms of how extensively this drug candidate could then be used, we think it's been very clear that this approach adds little additional toxicity to a standard transplant regimen for older patients who are usually the most affected. So we think even in younger patients, it would be perhaps even better tolerated, and especially for patients who might have low burdens of disease. And in fact, we've tested it in younger patients and shown just that. So I see no reason why this regimen wouldn't potentially be able to replace other conditioning regimens currently used in cases where patients are considered eligible for transplant for a variety of diseases, not perhaps even just malignant diseases, for, let's say, heritable disorders or other approaches where stem cell transplantation is used. But we're starting, obviously, with the patients who currently have no other options because that's the area clearly of the most pressing need.
Okay, thank you for that. Dr. Wall?
Yes.
Hi. So we'll direct the next question to you. Dr. Wall, it seems that we're talking about very high doses of radiation. You explained that major centers are well equipped to handle those, but Dr. Lazarus and Dr. Pagel spoke about eventual wide acceptance of Iomab-B. In your opinion, how feasible is that?
Well, I think maybe the experts in bone marrow transplant can speak to that. I mean, it was at one time that bone marrow transplant was just done in a few places, and gradually as people became familiar with the successes and the logistics of the technologies expanded, across the entire country to many sites. And I think that the logical growth of this will be in specialized sites that are more familiar with dealing with the radioactivity. And then if the results are confirmed in larger patient numbers, expansion to other sites will be feasible. Basically, most hospitals, the vast majority of hospitals that do stem cell transplants would also be sites that take care of patients with thyroid cancer. So I think that, logistic and licensing issues may differ by state, and there may be specific room issues, but I don't see any insurmountable barriers to expanding the therapy, particularly if these excellent results are confirmed in larger studies.
Great, thank you. And then we'll direct the next question to Dr. Pagel again. Dr. Pagel, if this approach is so promising, Are there many other radio-label antibodies in development for bone marrow ablation?
There are not many that I know of, certainly not in late-stage clinical trials. The approach is obviously logical, and you've heard that yields excellent results, but it takes a lot to actually move this from a conceptual stage to the clinic. We all are aware of that. You have to, of course, have an antibody that is appropriate for targeting with high affinity. It has to bind to the antigen and not be shed into the circulation, and a variety of other factors. And then, of course, on the radioisotope side, you need to match the energy and path length of the radionuclide to the properties of the target and many other things, which I think we've done well by targeting BCA to CD45. And, of course, without saying, it has to actually work in patients, and the bottom line is that it becomes very difficult and a long way to go from the concept to the clinic. That's why I think there are not many drugs at this point based on this approach out there, but I think this is an ideal setting for this in an incredibly highly unmet clinical need.
Well, thank you for that. We have another question here. Also, we'll direct this to Dr. Pagel. Can you talk us through the procedure versus the current standard of care? More importantly, which physicians will be administering the antibody?
Oh, I think this is a really important question, and the answer is that there is no standard of care for how this is done. This has the opportunity, I believe, to establish a standard of care. This would be only, as well I know, approach that would be FDA approved for stem cell transplant in this way. And as I mentioned earlier in the prior question, it has potential to be wide-reaching in potentially all types of hematopoietic stem cell transplantation approaches. So there is no standard of care, but this could become that, I think. The other thing to say is, and this also is part of the question, is that really it is the treating oncologist, it's the person who controls the transplant who's actually delivering the therapy. It is in coordination with experts like, let's say, Dr. Wall at his center, who would deliver in conjunction with the oncologist this drug. It is a team effort, but it is controlled, and technically it's delivered by the oncologist. It's delivery of an antibody in a way like we deliver rituximab, as an example, for lymphoma patients.
Great. Well, thank you for that, Dr. Pagel. So it looks like we have run out of time. I want to first thank our esteemed panel for joining us today on this very informative webinar, and then also thank everyone for dialing in and logging in. And thank you. Thanks again. Bye-bye.